Okay, well, welcome to this week's PGY2 Pain and Palliative Care webinar series. Our speaker again is Dr. Brad Ray. He'll be talking on fibromyalgia. Thanks for being our keynote speaker once again, sir. And
Thank
the
you.
floor is all yours.
All righty. So starting off with fibromyalgia, the first thing I'm going to talk about is the history a little bit. So originally when it was first kind of brought up, it was called fibrositis. And that was because it was thought that it had a more peripheral aspect to it. Now, in more recent time, we have found out that it is more centrally driven. However, there are still peripheral and autonomic aspects of the disorder. As far as the pathophysiology goes, I'll talk about it a little bit, but it's one of those disorders that we don't know a whole lot about. It is in the category of a central sensitivity syndrome. Some other diseases in that system are chronic fatigue syndrome, Gulf-War syndrome, IBS, PTSD, and restless leg syndrome. So they're all kind of in the same kind of categories of central sensitivity syndromes. So in 1990, the ACR, or American College of Rheumatology, essentially published classification criteria how to diagnose this disorder, and that had to do with tender points. Essentially what they wanted physicians to do was to push on certain areas of the body. Typically you'd push hard enough where you would see like a white area of the skin and see if the patient had pain. So later on, they actually in 2010 came up with new rules, finding out that the tender points weren't that beneficial in helping to diagnose it. Physicians weren't necessarily doing it right, and there was a lot of controversy of whether it was really beneficial. So they changed it in 2010 to include essentially looking at their patient's pain in different areas as opposed to trying to elicit pain. And they also looked at symptoms, and are one of the big problems with fibromyalgia. Now you can see there are only 3 drugs that have been FDA approved starting in 2007 and ending in 2009, which is pregabalin, duloxetine, and milnacipran. Now, interestingly enough, there are other medications that are used for fibromyalgia, and some that actually have a little bit better data than the ones that are listed, one in particular that I'll talk about a little bit later. So as far as what it is the second most common rheumatologic disorder behind osteoarthritis. And here are some of the main symptoms with it. So the pain that you essentially have with fibromyalgia changes typically with location and intensity, depending on the disease course, and it changes over time. A lot of times this has to do with what we call central sensitization. So it has to do with allodynia and hyperalgesia. So allodynia is essentially having a pain response in essentially a stimulus that wouldn't normally cause a pain. And hyperalgesia is something that would cause pain, but is a heightened pain response. Some other main symptoms of fibromyalgia are fatigue, cognitive dysfunction, sleep disturbances, and depression. Depression is really high in this disorder. Typically 80 to 90% of patients have some form of depression. It has been noted that there is some genetic risk factors associated with the disease. However, we do not really know which genes or alleles are associated with it, or I couldn't find any data to support which genes or alleles are associated with it. One thing that's interesting also is that typically patients with fibromyalgia have a 50% increased pain response. So essentially, if you look at a patient without fibromyalgia and a patient with fibromyalgia, and you essentially hit them in the arm at the same force, the patient with fibromyalgia typically will have 50% more of a painful experience as opposed to someone without fibromyalgia. So this is something interesting. So the prevalence and the cost of this disorder. So the studies vary pretty much as far as the prevalence goes, and that's due to the problems of diagnosing this disorder. But typically studies range from about 1 to 3%. Now there are some that go up to 8%, but typically it's about 1 to 3% of the population in the United States at least has this disorder, is thought to have this disorder. It typically affects middle-aged women, aged 20 to 55, and you can see here some statistics for cases per 1,000 person years, and it's about twice as likely to affect women as it is men. So as far as the annual healthcare cost for patient, this includes medications, doctor visits, hospital visits, and everything in between. The CDC came out and said it was essentially about $9,573 to treat this disorder. However, there have been about 3 or 4 other economic studies that have looked, ranging from $12,000 to $18,000, depending on which study you look at. Now, on the right, you'll see a little graph looking at treatment and societal costs. This was a study done in 2012 assessing the medications commonly used in the treatment of fibromyalgia and how much it actually costs society. And so this takes into account, again, medication costs, hospital visits, and time lost from work. So you can see this study actually found that it is beneficial economically to treat fibromyalgia when you look at placebo versus amitriptyline, pregabalin, duloxetine, and milnacipran. And you can see that overall, amitriptyline is actually found to be the most cost effective, not only because of the fact that it is an older medication and it is generic, but also it essentially has reduced costs for hospital visits. Now, another interesting statistic I found that over a 9-year period, fibromyalgia in the United States has actually accounted for $1 billion in hospital charges alone. So that's not including driving to the hospital with gas, that's not including doctor visits, it's not including medication costs, that's just hospital charge dollars, which would be also medications in the hospital, but nothing outside of it, which is a huge expenditure and is a huge problem that we need to start dealing with. So as far as the pathophysiology, I did mention that it does have to do somewhat with central sensitization. Essentially what that is decreasing the threshold it is required to produce a noxious pain response. I'm not going to get too much into the pathophysiology because it's still not super well understood, and I don't think it's a huge part of understanding how we're going to treat this, since we don't really know how this disease progresses and how it is actually forms. But there are some interesting factors that we can look at patients with fibromyalgia and determine if they do have some risk factors or if they do have the disorder. One of them is looking at CSF fluid. Now, it's not something we would typically do. However, when you look at the CSF fluid in patients with fibromyalgia, they actually do have decreased levels of serotonin and norepinephrine compared to a patient without fibromyalgia. Another interesting fact I found is that they typically have increased levels of endogenous opioids. Now, this has been speculated that since they do have these increased levels of endogenous opioids, and they still are having pain, it suggests a decreased sensitivity towards opioid usage, which is typically why opioids are not preferred in fibromyalgia outside of Tramadol, which is something that is thought about today, that Tramadol is really the only opioid we use in fibromyalgia. It also has aspects of the peripheral and autonomic nervous system, and there is some speculation about other factors, kind of with any disease, that it could be helped to get kind of egged along with stress, sleep disturbances, and possibly nutrition. Now, there's always other environmental factors that could have an aspect in the development of fibromyalgia, but as of right now, we are not exactly sure of why we developed this disease. So as I said, in 1990, the ACR did bring out diagnosis criteria. However, in 2010, they were changed, and this is the new 2010 diagnosis criteria. So there's essentially 1 to 2 criteria that you have to meet to actually be diagnosed with fibromyalgia, and it's based on 2 different factors. The first factor is the widespread pain index, and this is essentially looking at different areas of pain the patient has had over the last week. And here's an example of a list that a patient might receive determining where they have had pain. So they would essentially look at this list and check off areas where they have had pain in the last week. The other aspect of it is a symptom score, and this is based on the last 7 days or the last 6 months of symptoms. And you can see the different criteria here. You have to have at least 7 and at least greater than 5. So you have to meet both criteria to be diagnosed. But some of the symptoms that we really think about are fatigue, trouble thinking or remembering, and waking up tired. There are some other ones that we look at, and you have to bring all these factors in together to actually be diagnosed with fibromyalgia. Unfortunately, with fibromyalgia, we don't have a set diagnosis. There's not any actual levels or any things that we can look at to help diagnose fibromyalgia. So typically it is a diagnosis of exclusion, which you will see here with differential diagnoses. So a lot of times we're going to look at these different diagnoses to see if they have these before we're going to go and say the patient has fibromyalgia. And that's because there's no specific lab or abnormalities that are found. A lot of these other disorders, there are abnormalities found. So we can say that they have some of these disorders, but if we can't really find anything, typically we might say, well, this patient probably has fibromyalgia, and then we can move on to treatment. As far as treatment goes, there is a lot of data out there looking at different treatments, and I will talk about quite a few different ones. There was a research paper released in 2016 that kind of looked at some of the treatments that we currently use, and I'll start with the non-pharmacologic treatments. So all of the next 2 slides, they are all grade A evidence. However, only aerobic and strength exercising has a strong recommendation for use. All of the other non-pharmacologic and pharmacologic treatments are all a weak recommendation. So that is expert opinion, and it all is specified as good evidence. However, only the aerobic and strength training has actually been shown to be extremely beneficial in the treatment of fibromyalgia. Some of the other things we can do is cognitive behavioral therapies, acupuncture, hydrotherapy, and meditative movement therapies. As far as drugs go, or the pharmacologic treatments, which we would be more interested in, there are quite a few here, and there will be more than I talk about on the list, but these were the ones that were included in this study. They're typically the tricyclic antidepressants, particularly amitriptyline, the anticonvulsants, particularly pregabalin. Gabapentin has been studied to some effect, but it hasn't been statistically significant in any of the studies that I have found. The SNRIs, Tramadol, and muscle relaxers. As far as the muscle relaxers go, typically cyclobenzaprine is the one that has the most data. And I'm not sure if that's because cyclobenzaprine is similarly structured to a TCA, or if it's just because there's not a whole lot of data in the other muscle relaxants. So the first medication I'm going to assess is amitriptyline. So there was a meta-analysis done several years ago that included 10 studies with 612 patients. And what they essentially found with amitriptyline use is that to achieve a 30% pain reduction, you would have to treat 4 patients. And one of them would have that 30% pain reduction, which is significant, not only statistically, but from a clinical aspect, that does seem very beneficial. Now, as far as the dosages, this meta-analysis looked at, the dosages ranged from 10 to 50 milligrams, and the study durations ranged as well. However, when looking at this, really the only successful period of time that has been, currently appropriate, or that has been, affirmed, is 3 months. So 3 months of therapy. After that, it hasn't really been beneficial. It hasn't been shown to be beneficial. And you'll notice that a lot of these medications, it does seem that they're kind of time dependent in their efficacy that typically falls off. As far as another study that I looked at, this was another meta-analysis done a little bit before that, and it looked essentially at fatigue, sleep, the patient's own assessment of their symptoms, and then the physician's symptom thoughts for the patients. And you can see that most of the studies were significant in improving pain when amitriptyline was used. However, this study found something very interesting. When they looked at the actual dosages of amitriptyline, they found that amitriptyline 25 was found to be more beneficial than amitriptyline 50. And they didn't really speculate why. They was a very interesting finding that they thought, but they found that the 50 milligram dose had only significant improvement in sleep disturbances, which would make sense. And that's because amitriptyline is a tertiary amine, so it is going to have more of those anticholinergic side effects, which could induce sleep. Another interesting thing about amitriptyline is that it is one of the agents with the best data, which you'll see in a couple of slides. However, it's one of the only agents that's not FDA approved. So the 3 FDA approved agents are pregabalin, milnacipran, and duloxetine. Amitriptyline is not FDA approved, even though it does have some of the best data out of these agents. As far as the SNRIs, there was another meta-analysis done, which was only studied up to 6 months. So really we can only support use for up to 6 months. But you can see the number needed to treat for a 30% pain reduction in both of these was essentially 9 and 11. There are target doses that the study assessed. So duloxetine, the target dose was 60, and then milnacipran, the target dose was 100 to 200 milligrams. But both of these studies did show a beneficial effect of these medications versus placebo. Now, when comparing the 3 medications I currently talked about, the same study actually looked at this comparison and compared medication to medication. So when they did that, the first comparison they did was actually amitriptyline versus duloxetine. And what they found is that amitriptyline was better in pain, in sleep, in quality of life, and pain reduction for duloxetine. The only thing that wasn't really beneficial was that it did have an increased effect on the patient's fatigue, which is likely due to the anticholinergic side effects. When we looked at amitriptyline versus milnacipran, everything was also more beneficial as well. It's interesting when you look at this because amitriptyline, like I said, is not FDA approved, while these other agents are FDA approved. And then when you look at duloxetine versus milnacipran, duloxetine was typically more beneficial versus milnacipran. So when I think about the actual beneficial effects of these and which one I'd go to first, even though amitriptyline is not FDA approved, it's likely the first agent that I would go to unless there's some other kind of confounding variable that's either contraindicated the use of amitriptyline or the you wouldn't recommend it in a patient, for instance, if they're extremely drowsy and you wouldn't want to make them more drowsy. The second agent that I would say that would be beneficial would be duloxetine, which is sometimes thought of a first-line agent because it is FDA approved, and milnacipran. As far as the anticonvulsants go, really the only one with sufficient data is pregabalin. Like I said, there is data for gabapentin, but it's not positive data. They couldn't really find any statistically significant changes between gabapentin versus placebo. So this medication has also only been studied up to 6 months. And as far as dosages go, they haven't found a big difference in dosages to treatment effects. However, the one big thing they did find was that once you got over 600 milligrams per day, or around 600 milligrams per day, you did have a significant increase in adverse events. So you can see when looking at the actual data, it does have beneficial data. And you can see there was a large meta-analysis. There's actually a Cochrane review, which is typically thought of as better evidence than a meta-analysis. So you can see the pain reduction, the relative risk was 1.59. All of them were statistically significant other than the serious adverse events. So even though the withdrawal due to an event was statistically significant, the serious adverse events comparing pregabalin to placebo was not statistically significant. So pregabalin also does have some positive data in the treatment of fibromyalgia, likely why it's FDA approved. As far as tramadol, so there have been roughly 2 studies that I could find.
Hey, Brad, can you hear me? Brad? We can't hear you. Can you make sure you're not muted or something? I heard a squelch and then it left. We can't hear you, Brad. No, not through the computer. Mm-mm. Oh, it's showing your, try it now.
Hello?
Okay, now you're good. Now you're good.
Okay. When did that go off so I can go back?
It went off, I don't know. I think you'd be okay. What was your previous slide?
The comparisons,
Go back one.
the SNRIs.
I think I would say maybe 2 or 3 minutes. Does that sound right to everybody else?
That's weird. I'm not sure why my volume went off. Sorry about that, guys.
Oh, she's saying at the beginning of tramadol. So it might have been different for everybody else, but can you just start over at tramadol and we'll keep rolling? Sorry about that.
Yeah, no, it's fine. I seen you trying to do something, but I couldn't hear what you were saying either. So I will continue from here. So essentially tramadol, there's been 2 studies that have assessed tramadol use in fibromyalgia. The first one, you looked at tramadol in mice, and then the second one looked at tramadol plus Tylenol versus placebo. You can see the average doses of tramadol were 200 to 300 milligrams per day, which would have been split up. And you can see there was an improvement in pain response. Now, interestingly enough, there was a higher relative risk in the 50% improvement. Now, while that may not seem intuitive, that's because what you have to think about is you're comparing the active group to the placebo group. So that relative risk is going to be higher because there's not going to be many patients in the placebo group that actually had a 50% response or improvement in pain response likely. You can see the discontinuation rate was non-statistically significant, even though the relative risk was 1.62. The confidence interval did go through 1, so it cannot be said that it was statistically significant. As far as why tramadol is used over other opioids, now we know tramadol does have mu-opioid properties with very, very low effects on other opioid receptors. But other than that, it also does have other effects, and that's typically the reuptake of norepinephrine and serotonin. Now, it does have more of an effect on serotonin, less of effect of norepinephrine. That's likely why this medication has beneficial effects in fibromyalgia. So another one that is commonly used is muscle relaxants. The one that is studied most is cyclobenzaprine. You can see here that there was a meta-analysis done, and that most of the studies actually were statistically significant, and the odds ratio did not go through 1. The average daily dose of cyclobenzaprine was 30 milligrams per day, and that's usually split up, so it'd typically be 3 times a day. So looking at the actual sleep and the pain, you can see that it did improve at all times throughout the study up to 12 weeks of the studies. However, that did start to fall off, and that is pretty common with some of the other medications that we use. So it does appear that therapy could wean over time, which might be a problem. However, it is beneficial, at least in the beginning. One of the big things with this is that 85% of the patients taking the medication did experience an adverse event or a side effect, and that's typically the somnolence or tiredness associated with the cyclobenzaprine use. When looking at it, the big thing they found was a reported self-improvement. So whether that's due to a placebo effect or whether that's due to actual improvement, it's hard to say. However, they found a number needed to treat about 5. It was a little bit low, but we would round up to 5. So typically you would need about 5 patients treated with cyclobenzaprine to have 1 beneficial effect. And you can see the odds ratio was 3. That was statistically significant. So they did have a self-reported improvement with the cyclobenzaprine. There were some weaknesses that I do want to point out in this study. One of them, which the author stated, that there was a high likelihood for publication bias. There was a high dropout rate in these studies, and then there was a difficulty blinding. And that has to do with that 85% of patients having a side effect of the medication. They did actually ask patients in the studies because there were some crossover studies. So there were 2 studies where they looked at the crossover and asked patients, do you think that you had the active or the placebo? And 65% of the patients were accurate when they were on the cyclobenzaprine, likely due to the side effects of the medication. So something more recent and more interesting was looking at low-dose naltrexone for the treatment of fibromyalgia. And they compared naltrexone to placebo. This study included 31 women, and it was a randomized, double-blind, placebo crossover study. So it was a well-performed study. So you might be wondering, why would they do this in the first place? Naltrexone is typically used to treat either alcohol withdrawal or opioid dependence, or to help patients that are on opioids. Well, naltrexone, as it does have effects on the opioid receptors, it does have data in other chronic conditions similar to fibromyalgia, such as Crohn's and multiple sclerosis. So the effects aren't thought to be due to opioid receptor blockade. Rather, they think that the effects may be due to attenuating the inflammatory processes. This includes possible antagonism of immune cell receptors in the central nervous system, particularly the microglia. So you can see here that they did do a crossover study, and it was statistically significant and beneficial on this low-dose naltrexone of 4.5 milligrams per day, not only in pain reduction, but also in improved general satisfaction and improved mood. Now, there was no change in sleep, and there were increased side effects in the naltrexone group, naltrexone group, rather. So the most significant side effects in the naltrexone group were vivid dreams and headaches. Those were the only 2 that were statistically significant versus placebo. which I don't think patients would be that worried about, at least the vivid dreams, depending on how bad the headaches were. They didn't specify the actual severity of the headaches. They just classified it as the patients had an increased risk for headache when they were treated with that low dose naltrexone. Another area that's been looked at recently is cannabis use. So there was a study that was done that included 56 patients that looked at, essentially, did cannabis use help the symptoms of fibromyalgia? So as far as the actual characteristics of the patients in this study, there were the 28 patients in the active group. So 11 of them smoked cannabis or used cannabis less than 1 year. 9 of them were between 1 and 3 years, and 8 of them were more than 3 years. Now you can see here from the graph, essentially what we're looking for is, so the gray bar is the pre-cannabis levels of either pain, stiffness, relaxation. The black bars are post-cannabis pain, stiffness, relaxation. And you can see that in pretty much every aspect, it is beneficial. So they had reduced pain, reduced stiffness, increased relaxation. They did have increased somnolence, which could be either beneficial or not beneficial, since one of the side effects of this medication, or one of the side effects of this disorder, is fatigue. But also the sense of well-being was also beneficial. And you can see they all were statistically significant. Some more than others, but the P level on all of them did meet that level to essentially show statistical significance. The study went on to essentially look at other symptoms and perceived relief in these fibromyalgia patients that were using cannabis. And across the board, they were more beneficial. So you can see by this graph that essentially the black bars are, very strong relief. The gray bar is mild relief. The next bar would be white, would be no relief. And then from there, it's either worsening of pain. So you can see that in no places that had been listed did the pain or the anxiety or the headaches actually get worse. In every symptom category, it was improved. Now, when looking at the study and assessing the study, there are some problems. One thing, not necessarily a problem, but more of a problem with validity, would be that the majority of the patients were female, greater than 95%. Now, although females are more likely to develop this disorder, that does kind of put a hitch in the fact of using cannabis in males with the study alone. A beneficial thing of this study was that all the patients that were in the study, at least in the active group, had already failed conventional treatments. So they already tried the duloxetine or the amitriptyline and they failed, so they went on to cannabis. Another big factor that I think could have a very big bias in the study, that these patients were recruited from a cannabis association. So it's not like they were fibromyalgia patients that weren't part of cannabis. So they could have had some kind of bias in actually wanting to see an improvement to get this approved for fibromyalgia so they could intake cannabis either legally or easier had they not had the disorder. One of the last things that I'm going to talk about as far as therapy goes is exercise therapy. Now, as I said earlier, this is one of the only areas that has a strong recommendation according to the 2016 paper that was released, and it may have effect somewhat due to this study potentially. So one thing that's interesting is with exercise therapy, they classify it as a narrow therapeutic window, which typically when drugs, we think about it, it has a very low area to be successful. And it's similar with exercise, saying that if you do too little, it's not going to have an effect. And if you do too much, it's going to be more detrimental than beneficial. So it's going to be important for these patients that do undergo exercise therapy to start slow and to kind of build up their way so they don't overdo it and actually exacerbate their symptoms to make it worse. There is no optimal regimen for exercise therapy. However, it is recommended to do a variety of exercises between aerobic, strengths, and potentially aquatics. The biggest thing is essentially getting the patients to actually do the therapy. So this is going to be getting the patients at a gym, whatever's most convenient for them, whether it's at home and just having weights and doing Pilates and yoga. Even those types of exercises have some data in fibromyalgia to support that it may be beneficial. They did find that you can actually go to moderate severity exercise after some point without the detrimental symptoms, as long as you don't overdo it. So you can see here, this is a correlation analysis that was done assessing either aerobic, strength training, mixed training, or aquatics in the helping of fibromyalgia symptoms. So now it is a correlation, so we can't make cause and effect. However, we can correlate that either aerobic training or strength training was beneficial in the effects, the symptoms of the patients. So you can see across the board, strength training was the most beneficial in all of the categories, apart from fatigue. Also, with the mixed, it does have a good effect as well. Aquatics does have a good effect as well, but the aerobic exercise is not that beneficial in the treatment of fibromyalgia. It does have a beneficial effect in the physical function, such as cardiologic or cardiovascular function, but apart from that, it doesn't have a huge effect in the treatment of fibromyalgia. So if you have a patient that's wanting to go run marathons for their treatment, that's not going to be near as beneficial as if they go in the gym and try to do a variety of different exercises to get their actual treatment. So where do we go from here? There is research being done on different antidepressants, mirtazapine, desvenlafaxine. Now, esreboxetine, that was a medication that was going to be tried, or was going to try to be approved for fibromyalgia. It was developed by Pfizer, but it was discontinued in 2012. And that's particularly due to the fact that it didn't have any beneficial effects over conventional therapies right now. So they decided to discontinue it in the phase 2 trial because they did not think it would be more beneficial than any of the other conventional therapies, therefore not adding anything to the pharmacologic regimen. Another interesting area that could potentially be looked at in the future is testosterone. It does have positive data in some animal studies at reducing pain. So when we think about this, painful stimulus is usually when it happens, it induces an increased level of substance P, which kind of correlates with the whole capsaicin use for like osteoarthritic pain. So what substance P does is it activates aromatase and converts testosterone to estradiol. This leads to a release in endogenous opioids to downregulate the substance P. So for one thing we have to think about, this particularly happens in women as far as fibromyalgia diagnosis. And what happens is women typically have a deficient amount of testosterone. So this is going to lead to an increased level in substance P. So it is speculated that potentially giving testosterone to women or men that have this disorder could be beneficial in releasing those endogenous opioids to downregulate the substance P. Another big thing that's being looked at is the genetic components of fibromyalgia. Right now, we really don't know. We know there is a genetic component, but we don't know which specific allele or how we can actually determine if it's going to be passed on to children or how we can genetically test for it at birth. Also, another big thing in the research is trying to figure out which receptors and biomarkers can we use to actually diagnose the disease. As I said, right now, it's kind of a diagnosis of exclusion. Some people think that it's not even a true disease. Some people think it is. The research out there makes me think that it is a true disease, that patients do have this. However, it's so hard to diagnose accurately that it's one of those that is just kind of a problem right now. And we really need to find out more ways to diagnose the disease other than subjective assessments of the patient's pain. As far as that goes, sorry, slide, then move over. However, here's everything I just kind of said with the mirtazapine, desvenlafaxine, the NRI, so the esreboxetine, that was actually norepinephrine reuptake inhibitor, which was somewhat unique in its class, but it did discontinued. As far as that, I will take any questions at this point. So typically our agents that we're going to use from my standpoint would be amitriptyline first, and then you could either try pregabalin or one of the SNRIs. And then after that point, I would try one of the other agents, cyclobenzaprine, tramadol. Obviously, I would recommend exercise therapy in this patient since it does have the strongest recommendation for helping. And right now in our area, we have no doctors that would prescribe cannabis for these patients. So it's not something that I need to really worry about at this point. But I know in other areas in the country, it is a potential use. But I think more research really needs to come out to say definitively that cannabis does help in fibromyalgia treatment. So I'll open it up to you guys for questions.
So Dr. Ray, do you feel like based on what you've found that that the benefits of amitriptyline may extend to other TCAs where we could potentially rotate between them based on tolerability?
I think there's a potential. I think one of the big things with amitriptyline is that it is a tertiary amine. So if we were to rotate it, I'd want to keep it within the tertiaries, maybe with imipramine, due to the effects with the anticholinergic side effects, potentially helping with sleep, since some of these patients have problems with sleep. I think it'd be a good area to look into. I just don't think the research is out there to support that right now.
Okay. I wonder what doses of cannabis they used in their study. Like if we could get away with using some of the commercially available preparations now, or what the mix was between THC and some of the other cannabinoids. I don't know. It's fascinating to me.
I know when I read the study, they did say the patients had varying amounts of cannabis intake. I didn't look into as deep as how much THC they actually intook, but that's something that I could definitely look into to determine if there is potentially a level that's more beneficial THC intake per day, or if it's just patient specific.
So here's a really off the wall question. I know you work in hospice.
Yes.
How would you feel about cannabis use in the hospice population?
Me personally, I am not as against it. In the hospice population, for one thing, they kind of have the say so. Families and patients, we can give recommendations to them. We can make recommendations for side effects, but when it comes down to it, it's really their choice. And I do know there's probably about 5 or 6 patients on hospice right now that do intake cannabis, and they're honest about it. And it's not something that's going to make us not want to treat them or anything because they're on hospice. I mean, they're at end-of-life care. I would be okay with patients, especially with disorders that have good data to support use. Now, obviously, a random patient that wants to smoke cannabis for whatever, I wouldn't recommend. But if there's data to support its use and treatment of the disease or disorder they have, I would be okay with that in the hospice population.
Okay.
But I know opinions vary on that, so that's very subjective.
Okay. I don't know if you have your chat screen open. You have a question from, it looks like Pano. From Pano. There you go.
Is there any data regarding how many of these patients are overweight or diagnosed? I did not see any data for overweight or type 2 diabetes diagnosis associated with fibromyalgia. I'm not saying it's not out there. It's not something that I had come across in making this presentation.
Any other questions for Dr. Ray before we sign off? Give people a minute to find their mute button. It takes a minute. Alrighty, well, as always, great presentation. Next Friday, we'll be talking a little bit more about medicinal cannabis. So please consider tuning in, telling your friends, making your trainees jump on. And for those of you who would like to go back and review this, if need be, the recordings of these Friday webinars are posted under the members section of the Society of Palliative Care Pharmacists. So again, thank you, Dr. Ray, for another phenomenal presentation. I always learn so much from you. And everyone have a great weekend.